like to introduce our first speaker, Dr. Huang. He is a transplant nephrologist and is chief of the Department of Transplant Nephrology at the UC Davis Medical Center. Dr. Huang graduated with a Bachelor of Science from Stanford and then went on to medical school and residency in internal medicine at the Washington University School of Medicine in St. Louis. Following were the fellowships in nephrology and transplant nephrology at the University of Michigan. During this last period, he squeezed in a Master of Science degree at the University of Michigan in clinical research design and statistical analysis. Dr. Huang is now the interim medical director for the kidney and pancreas transplant program at UC Davis. Everyone, please help me in welcoming Dr. Huang.
Yeah, so thanks for having me, and yeah, glad to be here, and it's good to see some familiar faces too. And congratulations to those people who had got a kidney transplant at UC Davis and also elsewhere. So today I'm going to, so Linda has asked me to speak a little bit about the UC Davis Kidney Transplant Program. And also, she asked me to speak about preemptive kidney transplant, which means getting a kidney transplant without having to go through dialysis. Now, and that ties in well our mission at UC Davis to try to shorten the waiting time to kidney transplant as much as possible. So those are all topics we're going to cover today. And then at the end, also talk about the transplant evaluation at UC Davis. So yeah, we'll start with talking a little bit about the benefit of kidney transplant compared to dialysis. Why is kidney transplant better for those who are suitable candidate? To start with, we'll talk a little bit about what the kidney does. So one of the major functions of the kidney is to filter blood to get rid of the waste product from the body. So each of us, most of us are born with 2 kidneys, and this is what the kidney looks like. Yeah, so here's what the kidneys looks like. So the blood goes into the kidney, get filtered by one of the millions of nephrons, which are the filtering unit of the kidney, and then the clean blood returns to the circulation. So this is what each of the nephron looks like. And the part that's the most important in the nephron is this part called glomerulus. So what it is, it's basically a filtering unit, and that's where the blood gets filtered. And if you look at under the glomerulus under the microscope, it's this intricate, delicate structure with a lot of small fingers interlacing together, and that forms the filter of the kidney. And it's a smart filter because it filters out the waste product, what the body doesn't need, but it also then keep in what the body needs, for example, protein. So waste product goes out, but the useful molecules stays within the circulation. So it's a smart filter. Now, how much do the kidneys actually filter? And that's what we refer to as the glomerular filtration rate, which is an important measure of kidney function, and shortened for as GFR, which you might hear from time to time. Normally, the 2 kidneys working together, should be filtering about 100 cc a minute, and so that's what we refer to as 100% kidney function. So how much is 100 cc unit? It's actually slightly less than the half a cup, so which may not sound like that much. But remember though, our kidneys are working nonstop, 24/7, nonstop. So over the 24 hours, that's actually the 144 liters within the 24-hour period. And it doesn't show up that well. But yeah, here's a 2-liter bottle. And so 144 liters, that's actually a lot of blood that the kidneys are filtering. So our kidneys are working hard. People with chronic kidney disease, though, the glomerular filtration rate goes down over time. So their kidneys are not filtering as much blood. So less waste product are removed. For stage 2 on chronic kidney disease, stage 2 CKD, the glomerular filtration rate has gone down to between 60 to 89. And then stage 3 is between 30 to 59. Stage 4, now that's what we start to refer to as severe chronic kidney disease. The filtration rate goes down to between 15 and 29. When you get to stage 5, the filtration rate is less than 15. Then people have to start thinking about dialysis. And when it gets below 10, people usually don't feel so well and have to be on dialysis. So, and that's what, so stage 5 is also what we refer to as end-stage kidney disease. Now, in order to get on the transplant waiting list, a patient will have to either be on dialysis or have glomerular filtration rate less than 20 cc per minute. And so you don't have to, so for people, so it's not a requirement to be on dialysis before getting on the waiting list. People can get on the waiting list if their filtration rate is less than 20 or 20% of normal kidney function. And for those people who are not able to get transplant, they have to be on the dialysis, either hemodialysis or peritoneal dialysis. So this is a picture of the hemodialysis filter, which is designed to replicate some of the function of the normal kidney. But it's not really entirely the same, though, and it's not entirely the same. So part of the issue is that with hemodialysis, we go to the center 3 times a week. That's only 12 hours of dialysis a week. And so with that 12 hours of dialysis, it just doesn't compare to what the kidneys do 24/7 nonstop. So with hemodialysis 3 times a week, about 12 hours, that's the equivalent of GFR, about 15 to 20 cc per minute. So basically, it still puts people in stage 4 kidney disease. So compared to what the kidneys do, it's really not that much filtering. With kidney transplant, because when people get a kidney transplant, it's only 1 kidney, not 2. So it doesn't actually restore 100% kidney function. But still, people usually get a glomerular filtration rate between 50 to 60. Some people are going to be lower, some people higher. So that's actually a lot higher than what's achievable with hemodialysis. Now, some people do home hemo and some people do nocturnal dialysis, which are longer treatment. So with this longer treatment, this number can actually get a little bit higher with hemodialysis, but still, it still doesn't compare what's achievable with kidney transplant. In addition, the kidneys actually do more than just filtering the blood. It helps regulate the blood pressure. It helps with production of red blood cells, and also it helps regulate the parathyroid hormone. So there's actually a lot of function that the hemodialysis filter does not provide. And that's why people on dialysis, they have to get the medication like Epogen, Procrit, and other, and also the Sensipar to replace some of the other functions provided by the kidney. And because hemodialysis and also peritoneal dialysis, it only replaces the kidney function incompletely. And so some of the toxic molecules can still accumulate over time. And that's why when people are on dialysis, there's actually the accumulation of long-term damage to the body over time. So people on dialysis, they can develop heart disease because the buildup of atherosclerosis, and which happens actually faster compared to people without the kidney problem. And also, nutrition can be an issue. People on dialysis, even though they're eating well, they're getting dialysis, but there's still malnutrition compared to people without kidney disease. And also, there's chronic inflammation as well. So those are all reasons that even with dialysis, there can be the slow accumulation of damage to the body long term. And those are the things that that can be fixed with kidney transplant. Now, one of the major cause of death when people have kidney disease is actually the cardiovascular mortality, which includes fatal heart attack and fatal stroke, and also dying from irregular heart rhythm. So this red line here is the risk of those cardiovascular mortality when people are on dialysis. And then you can see that it's quite high in every age group, but also increase as people get older. So after transplant, the chance of dying from a heart attack, stroke, and also irregular heart rhythm goes down by quite a lot. So that's one of the major benefits of kidney transplant compared to dialysis. However, because there are damages that accumulate over time when people are on dialysis, so even after transplant, some of those issues, some of those damage doesn't still go away. For example, people's blood vessels gets a lot stiffer, gets calcified with a lot of calcium buildup when they're on dialysis. And after transplant, that doesn't entirely go away. So that is why when we look at people who get a transplant, what we found is that the shorter they've been on dialysis before transplant, the better they'll do after transplant. Generally, the longer they will live. So someone who only needs to be on dialysis for a year before they get their transplant would, on average, live longer than someone who need dialysis for 8-10 years before getting to their transplant. So shorter time on dialysis equals longer survival after transplant. Now, next, I'm going to move on the advantage of preemptive kidney transplant. So that's when people get a kidney transplant before even needing dialysis. Now, we just talked about that shorter time on dialysis equal longer survival after transplant. So I just also want to emphasize that what I mean by shorter time on dialysis, that's the months and years that people on dialysis before they get to a kidney transplant. I'm not referring to the number of hours people get the number of hours of dialysis people get each week. Yeah, because with the number of hours of dialysis, that's generally the more the better because you actually get your blood clean better. So here I'm talking about the months and years people have to stay on dialysis before getting to kidney transplant. So shorter time on dialysis, better survival after kidney transplant. And therefore, if someone is able to get to kidney transplant without having to go on dialysis at all, that's actually the best. So that's what we refer to as preemptive kidney transplant, before the kidneys fail completely to need dialysis and getting a transplant before that happens. So this is what happens when people get a preemptive kidney transplant. So here's a frowny kidney. It's someone with chronic kidney disease, and without having to go through dialysis, they go straight to transplant. So that's like taking a nonstop express train without making any stop. But it actually doesn't happen that much, though. Yeah, if we look at the number of people who reach end-stage kidney disease in the United States, only 2.5% they get a kidney transplant preemptively. So only 2.5%, and the vast majority start dialysis. So with dialysis, it can be either hemodialysis or peritoneal dialysis. Now, ideally, for people who need hemodialysis, they have a lot of preparation ahead of time. They get their fistula placed so they can start hemodialysis with a fistula. In the same way, peritoneal dialysis, you need to get the peritoneal dialysis catheter placed ahead of time and get the training to get on the peritoneal dialysis. And if everything goes well, hopefully this person who's on hemodialysis doesn't have to make any other changes before getting their kidney transplant. Sometimes the journey from chronic kidney disease to kidney transplant, can make multiple stops along the way. Some people, they may find out their kidney problem too late to get a fistula before they actually start dialysis, and therefore they have to start dialysis with a catheter, and later they may decide they want to do peritoneal dialysis. They say switch to peritoneal dialysis, but if things don't go well, they end up with peritonitis, infection in their peritoneal cavity. They may need to have a hemodialysis catheter placed, back on hemo, and then maybe fistula placed for long-term hemo. And you can see that this journey from chronic kidney disease and kidney transplant, for some people, there's actually multiple stops along the way, and every stop can be stressful because every stop, every change in dialysis modality, usually require procedure. It also increase the chance of infection, and then people have to rearrange their life completely. It may be time from work, away from work, from family. So every change can be stressful. Every stop along the way from chronic kidney disease to a transplant can potentially be stressful and cause some additional health issue for the kidney patient. So that's why, if people are able to get on the express train going from chronic kidney disease to transplant without any other stop, that's the best. However, we mentioned earlier that really doesn't happen that much. Why is that? If it's something that's good, why doesn't it happen more often? So, and I really like to think of it as the Swiss cheese model, and some of you might be familiar with it. What it tells us is that it's basically for something rare that happens, whether or not it's good or bad, usually a lot of things have to align correctly. So same with preemptive kidney transplant. For that to happen, a lot of stars have to align. So first of all, someone with kidney problem, they need to actually get it diagnosed early. Now, some people with kidney problem, unfortunately, they have no idea they have kidney problem because they have no symptoms. By the time they start to feel sick, and they eventually sick enough to go to the emergency room, it may be too late. They're told at that time that their kidney problem is already in stage, and they have to start dialysis right away. And obviously, in that situation, they won't have a chance of kidney transplant before needing dialysis, just because their kidney problem is discovered late. Now, even if the kidney problem is discovered early enough, and then the patient get referred to see a nephrologist, the kidney disease has to be slowly progressing for there to be enough time to prepare for transplant. If the kidney disease actually progresses rapidly and the glomerular filtration rate drops quickly, then the patient may need dialysis before there's time for the transplant preparation. And the third thing that has to happen is availability of a transplant donor. So usually with preemptive transplant, this will require a living donor. And that's because the waiting time for deceased donor in this country, and in California especially, has gotten so long that it's almost impossible to get to a kidney before dialysis by waiting for a deceased donor kidney. Still happens once in a while, but it's really pretty rare. So the majority of a preemptive kidney transplant happens with living donors. And the fourth thing that has to happen is that both the kidney patient and their living donor had to be referred to a transplant center, get evaluated, get all the testing done to make sure that they're safe for surgery, And so all this have to happen before the kidney problem gets bad enough to need dialysis. All of this have to happen for someone to get preemptive kidney transplant. Yeah, so it can be daunting, but for people who are fortunate enough to have it, it really is the best treatment to kidney problems. Now, and just because it takes a lot of preparation to get your transplant, so the time to actually start thinking about it is not when GFR is 15, it's not when people are needing dialysis soon. It's actually when GFR drops to about 30. So that's when people are advancing from stage 3 to stage 4, when their GFR drops down to 30. That's the time to start thinking about transplant. And that's the point that for people with kidney problem, they should start thinking about finding a living donor. They should start thinking about the transplant down the road. And they should also start thinking, the nephrologist should start thinking about getting them referred to a transplant center. So at that stage, so there will be more time for preparation. Now, so next I'm going to actually start with the rest of the talk. I'm going to focus on our program at UC Davis and our effort to reduce the waiting time to transplant. So again, that's one main theme of my talk, is that shorter time on dialysis means longer survival after transplant. Now, for most people, preemptive kidney transplant is out of reach. So the second best thing is to reduce the waiting time as much as possible. The problem is that the average waiting time is actually getting longer and longer, especially in California. So here's the national statistics. It shows that the top line here, that's the number of people on waiting list waiting for a kidney transplant. And in 2013, yes, got on to 99,000. And so this is actually older data from 2013. And I just checked last night. As of 2018, that number has actually gone past 100,000. So there are a lot of people in this country waiting for kidney transplant. But
is that California?
This is national. Yeah, this is the whole country. Yeah. So, but if you look at the number of people who are actually getting kidney transplant each year, that's the lines down here. So one line, this gray line is some people who get deceased donor kidney transplant, and then this darker line is people who get living donor transplant. And you can see that those lines have actually been sort of flat for many years. Now, after 2013, there's some increase, but still, it doesn't match the increase in the waiting list, and that's why the waiting list has been getting longer. So, and here is actually so this is for California alone. So this is the number of people in California waiting for a kidney in 2018. So it's more than 18,000 people. Yeah, more than 18,000 people in California alone. So that's actually enough people to fill the Oracle Arena. So that's a lot of people in California waiting for kidney transplant. Now, next I'm going to talk about our effort at UC Davis to try to reduce that waiting time to get people to kidney transplant faster. So we are a pretty big kidney transplant program. We've been around for quite a while. And at UC Davis, we've done more than 4,000 kidney transplants. And on average, we do about 250 to 300 a year. So we're one of the biggest programs in California. And also, we are in a separate OPO from the Bay Area. What does that mean? So by OPO, what it means is that those are the organ procurement organizations. In California, it's broken up into 4 OPOs. Most of the Northern California, and that's the olive green part that you see on the map, most of the Northern California are in the same OPO. And there are 3 kidney transplant programs in that OPO, and that's UCSF, California Pacific, and Stanford. And so all those 3 centers in the same OPO, they actually share the same waiting list, which means that you can only be on one of the 3 waiting lists. Yeah, but you cannot be on both. You can only be on one of them. UC Davis, though, in Sacramento, we have a separate OPO, and that's a smaller one here in the light blue. And UC Davis was the only program in that OPO. Now, if a transplant program is a different OPO, you can be on that list as well. So you can be listed in more than one OPO, but within each OPO, you can only be on one program. And there are 2 other OPOs in California, including the one surrounding LA, and that there are 10 kidney transplant programs there. And also one in San Diego with 3 kidney programs there. So for 4 OPOs in California, and then you can be on the different waiting lists at different OPO. And one thing that sets UC Davis apart from other kidney transplant in Northern California is that we actually have the shortest waiting time. So waiting time, it's different for each blood type. And at UC Davis, the waiting time ranges between 1.5 years to 6 years, close to 6 years for different blood type. So blood type AB has the shortest one. For blood type O and B, they're longer. So for example, for blood type B, the average waiting time at UC Davis now is 5.6 years in 2018. And so for us, like everyone else, the waiting time has been going up. And that's just the national and also the trend in the state. But we're actually still much shorter compared to other programs in the Bay Area. And because our waiting time is shorter, that means that once people get on the waiting list at UC Davis, they actually have a much higher chance of getting transplanted. For example, in July, this is the size of our waiting list in July 2018. There's about 1,200 people on the waiting list. And within a year, though, 309 actually got transplanted out of that 1,259. So that's about a quarter of our patients on the waiting list getting a transplant. And that's actually much, much better compared to, that's actually a much higher percentage compared to other transplant programs. So here's a comparison of our program at UC Davis with other 3 Northern California programs. So UCSF, California Pacific, and Stanford in the Bay Area. So out of 100 people on the waiting list, in a year, 26 get transplanted at UC Davis. And the number is actually much lower in other Bay Area programs. And we're able to do that because we have a shorter waiting time, and therefore more people actually get transplanted on the waiting list. Another way to look at the number is to see, once you get on the waiting list, what percentage actually get transplanted in 3 years? So at UC Davis, for those people who get on our waiting list, in 3 years, 45% get transplanted. So that's close to 1.5. And again, the number is much smaller in other it's much smaller in other Northern California center. So that's the advantage of having a shorter waiting list. People get transplanted faster, and also we get more people transplanted. Now, why are we able to do that at UC Davis? The reason is that we try to utilize more kidneys. We want to utilize kidneys, all kidneys that are available for kidney transplant. One thing a lot of people don't know about is that there are actually a lot of kidneys that the family donated for their loved one. There are a lot of kidneys that get procured but don't end up being used for kidney transplant because no centers want to use them, so they actually end up getting thrown away. They end up getting discarded. So looking at the national statistic, about 3,000 kidneys that are procured for kidney transplant. So someone donated their kidney after they pass away, wanting it to be used for transplantation, but 3,000 kidneys actually don't get used each year, and that's a lot of kidneys. Now, some of it's because the donor was too sick, the kidney is not really in good shape, and again, those are the situations that, yes, some of this kidney really shouldn't be used because they may never work, but still, out of 3,000, we believe that a lot of kidneys will work once it's transplanted and allow someone to get off dialysis. So that's our approach at UC Davis, trying to use kidneys. Other centers may find too challenging, and that's how we've been able to provide more transplants to more people and shorten our waiting time. So if we look at where the kidneys we use at UC Davis, where those kidneys come from, actually only 29% come from our local OPO, come from the Sacramento region. So that's actually a small percentage of the kidneys we use at UC Davis. There's about 20% that come from other parts of California, and then actually 51% come from out of the state. So next, I'm going to talk about some of these more challenging kidneys and how at UC Davis we're able to use those kidneys to shorten our waiting time to provide more transplants to more people. So we're going to talk about 3 categories. There's the kidneys with KDPI greater than 85%, and also the kidneys from donors with acute kidney failure, and also pediatric kidney from donors less than 7 kilograms. So KDPI, that stands for the Kidney Donor Profile Index, and so that's a score that goes from 0 to 100, and it's given to every single deceased donor kidney after it's procured. Now, the higher the number, it means that the kidney may not last as long compared to a kidney with a lower number. So the kidneys with higher number, they tend to come from an older donor, so who might already have some wear and tear on their kidney, and also donor who had a history of high blood pressure with diabetes, and also if someone died from stroke and donated their kidney afterward, their KDPI score is going to be higher. And then also someone who died from cardiac death, their heart stops. And so those are the factors that make someone's KDPI higher. Now, so those kidney with high KDPI, on average, they don't last as long as a kidney with low KDPI number, but still, it can still work quite a while, for quite a few years, and actually get someone off dialysis for many years. So here's the national statistic. So this bottom line here, the purple line, that's the kidneys with KDPI between 86 to 100. So again, that line is lower than every other lines. That means that this kidney on average don't last as long. But still, 6 years after transplant with one of these kidneys, 50% are still working. And I would say that for some people, that allow them to get a kidney transplant, and it will still provide them several years of good kidney function. And an unfortunate fact is that a lot of these kidneys are actually not used for kidney transplant because there are a lot of centers, they don't want to take on that risk. They don't have the experience using these kidneys. So when we look at kidneys with KDPI greater than 85% in this country, about 50% are discarded and never used for transplant. So I'll give you an example. So this is a transplant that happened at UC Davis in 2018, and it's from a donor who passed away in Southern California. It's a donor in his or her mid-60s, and this donor had a history of hypertension and died from stroke. So because of those reasons, the KDPI on this kidney is quite high, 95%. And their transplant center, when they see that number, they just pass on the kidney. They feel like that kidney is not going to work. So they just don't even consider using that kidney at all. So this kidney originated in Southern California, and none of the centers in Southern California actually wanted to use it. And that's how it came to us. We're willing to give it a chance because we feel that, there's still a very good chance that this kidney might work. So we were able to use it into a 70-year-old at UC Davis. It's someone with blood type O who's been on dialysis for 3 years. Now, and the kidney did not start working right away, and so that person still needed some dialysis after kidney transplant. But eventually, serum creatinine, actually, that person was off dialysis with serum creatinine 1.8. Now, serum creatinine 1.8, it's not that great. That still means that someone has stage 3 kidney disease, but it's definitely enough for someone to feel well and definitely be off dialysis. So this is an example that we use a kidney that other centers was not willing to use and use it successfully. And for this recipient, he was 70 years old at the time of transplant. He's been on dialysis for 3 years. If he has waited longer on dialysis, his health condition may deteriorate to the point that he's not safe for transplant anymore. So by getting the dialysis 3 years into his kidney transplant, now he's doing well. So that's one thing that we feel like we can offer at UC Davis. Sure.
The person that received the kidney with that high does it matter a lot about their own condition before riskier kidney?
You mean for the recipient?
Yeah. Does it matter other than that they're on dialysis? I mean, does it matter?
Yeah. So usually, yeah. So we do take other things into consideration. And some people, if they don't have a good heart, their heart may not be able to support more challenging kidney. So there is some consideration on the recipient side as well. Yeah. And also at UC Davis, we use more donors with acute kidney failure. So here's an example. It's a very unfortunate 20-some-year-old who lived on the East Coast and hospitalized for head trauma and ended up with multi-organ failure, and including kidney failure. So this donor was actually on the continuous dialysis before the passing away. And again, his kidney was turned down by multiple transplant centers. And that's how this kidney from the East Coast ended up at UC Davis. Now, because the donor had kidney failure, so this kidney actually took a long time before it recovered. And for our recipient was on dialysis for 3 more weeks after kidney transplant before our recipient was able to come off dialysis. But still, we believe that it's a kidney from a 20-some-year-old, which means that the kidney has good fundamental, good tissues, and should be able to recover from that kidney failure. Eventually, it did after 3 weeks of dialysis, and now the recipient has a serum creatinine 1.4, which is pretty good. So another category of more challenging kidneys that we use at UC Davis are tiny kidneys from pediatric donors. And so these are really unfortunate situations when the children and sometimes the baby who pass away, and the family wants to donate their kidneys, but the problem is that these kidneys are so small that they're actually very difficult, very technically challenging to do operation on these kidneys. At UC Davis, though, we probably have the most experience in the country in terms of using these tiny kidneys, and our surgeons actually have built up expertise managing these challenging kidneys. So, and even though the short-term complication may be higher just because the surgery is more difficult with these tiny kidneys, but if the surgery is successful, the long-term outcome is actually excellent. because these small kidneys can actually grow over time and actually provide excellent function for many, many years. Again, so one mission at UC Davis has been used to use these challenging kidneys that other centers decide not to use to offer our patient a shorter waiting time. And I would like to quote Dr. Richard Perez, and he's the chief of transplant surgery at UC Davis. So here's a direct quote. It's our position that every possible kidney that can be successfully used for transplant should be used for transplant in order to reduce waitlist time. We feel that it's a service to our kidney patients who've been waiting on dialysis for a long time. And I also feel that it's a way for us to honor the donors who pass away and want to donate their organs for other people to use. It really be a shame that someone donates an organ and then that organ ended up being thrown away. So I feel like this philosophy, our mission, is also to honor that gift of life. Now, so that's the approach at UC Davis, and we've been successful in terms of reducing waiting time. There is a slight trade-off, though, because we're using more challenging kidneys. Some of the kidneys, they do have a higher chance of failure by 1 year after transplant. So the graph here looks at the percentage of repeat recipient who's still alive with a functioning transplant. At 1 year after transplant, nationally, the percentage is 94.5%. At UC Davis, though, it's a little bit lower at 91.7%. So there's a slight trade-off by using these more challenging kidneys. But on the other hand, when we look at the 3 years after transplant, our patients actually do slightly better compared to the United States average. My feeling is that we're able to achieve that because we allow our patient transplant faster so that they have fewer accumulation of long-term damage from dialysis. So lastly, I'm going to talk briefly about transplant evaluation at UC Davis. Now, at UC Davis, we emphasize readiness for transplant, and that's because our waiting time is shorter. So once people get on the waiting list, we want them to be ready for transplant. Now, I have to say that, even though transplant can be a better treatment compared to dialysis, but it may not be for everyone. And for someone to do well after kidney transplant, that patient has to be able to tolerate surgery and also has to be able to tolerate being on immunosuppression long term, which can be pretty harsh on the body. And so when we see people evaluation, we want to make sure that they pass all the testing and the screening and they're able to do well after kidney transplant. So that will involve screening for cardiac disease, blood vessel diseases, infectious disease, cancer, and also everyone coming for evaluation is evaluated by our social worker to make sure that they have the financial resources to do well after kidney transplant, to pay for the medication, and also evaluated by our nutritionists to make sure that they don't have significant malnutrition. And one thing we also emphasize a lot at UC Davis is the physical activity performance, because what we found is that people who had good physical ability before transplant, they will do well recovering from transplant surgery. But those people who do not, they may actually do worse and actually dwindle more, deteriorate more after their transplant surgery. So at UC Davis, our requirement is to be able to climb stairs. We have 3 to 4 flights of stairs, usually from the 1st to the 3rd floor. And also, we want to see people being able to do activities of daily living independently. So that includes feeding, dressing themselves, and also walking without much assistance. So at UC Davis, now one feedback we get from our evaluation patient is that at UC Davis, people actually jump through a lot of hoops to get on the waiting list. And that is true. That's because we want to make sure that once people get on the waiting list, they're ready for transplant. As I shown earlier, once people are on the waiting list, within 3 years, about half will get transplanted at UC Davis. So we ask people to complete their testing before we put them on our waiting list at UC Davis. And that's why it feels like there are a lot of hoops to jump through before the getting listed at UC Davis. And this is a little bit different from other centers with longer waiting time. And at those centers where people actually wait for a long time, they may actually get listing first, but with an inactive status, just because they still have so much waiting time ahead of them, they don't need to be activated. And then after several years, when people are getting close to the top of the list, that's when the center may ask the patient to start doing testing. So the testing may come at the end, whereas at UC Davis, we ask people to finish all their testing before getting on the waiting list so that they're ready for transplant. And also, I just want to mention briefly our living donor program. Having a living donor is still the best way to get a kidney transplant faster and have a shorter waiting time. And at UC Davis, when someone brings a living donor, we expedite the transplant evaluation because we want to get that patient to transplant as soon as possible. So at UC Davis, the goal from transplant referral to living donor transplant, we try to make that happen in 3 months. So getting to the end of my talk, so here are the take-home point. Again, one thing that I keep returning to is that shorter time on dialysis means better survival after kidney transplant. And therefore, preemptive transplant without having to go through dialysis at all is the best. If that's not possible, then the waiting time is shorter the better. And at UC Davis, we're able to offer the shorter waiting time than other California centers. And that's because we use some of the more challenging kidneys other centers do not use. And we feel that we have developed experience and expertise utilizing those more challenging kidneys and taking care of patients afterward to have a pretty successful outcome. And so that's our mission, to offer shorter waiting time to transplant and allow more people to get transplanted. Thank you. Oh.